here today, who is able to join us today over the power of the internet. So, and through this session, we will be taking Twitter questions to make sure that this dialogue is open to everyone who's both here with us today in Hyderabad, as well as those of us who aren't able to make it. So, before I introduce our panel, I'll maybe just give a little bit of background on this meeting today, and sort of where the idea from it came from. So, the union has been increasingly interested in the life after TB, what happens after TB, and there was a union webinar held earlier this year, which members were able to join, going into some of the gaps in the knowledge we have about life after TB, and I find it fascinating. And some of the webinar members are here today, and I tweeted out my newfound enthusiasm and what I didn't know about life after TB. And I had a conversation on Twitter with a TB survivor who we spoke about her experiences of life after TB and her questions about life after TB and how she had so many questions she didn't know the answers to. And from that conversation that happened on Twitter, I reached out to our colleagues at the union, Kevin Mortimer, the director of the TB department, who I'll introduce in a minute, and Ingrid Sherman, the civil society rep, to say, I've had this conversation and there's a lot of questions out there about this, and this is where we decided that we would try a new format here at the union on having a conversation about this, but also making this conversation open to people who are not able to attend the conference. And so we have, for the last 3 weeks, been tweeting out about life after TB using the hashtag life after TB, and collecting questions from the internet, from people who have got questions, and then our panel today will be able to answer those questions, as well as questions from the room. And also, for those of you who are tuning in on the live stream, if you've asked a question, we will be answering it. If you think of more questions, again, we will try and answer them during this session. If you've just seen this live stream, you will be able to tweet in your questions. So if you have a question while this is going on, please tweet us on hashtag life after TB, and tweet us on the Union Conference Twitter account. And apologies, I'm a bit of a technological dinosaur, but I hope that's clear enough on how to get your questions. So without further ado, I will now introduce my panel, or the panel, sorry, our panel for today. First in the panel is Dr. Kevin Mortimer, who's the Director of Lung Health and a pulmonologist doctor at the Liverpool School of Medicine in the UK. Next is Ingrid Sherman, who's from TB Proof. Then next is Dr. Jamila Meghia, a researcher at the Liverpool School of Tropical Medicine and a practicing doctor in London. And finally, Dr. Brian Allwood, a pulmonologist doctor at Stellenbosch University in South Africa. So, to open our conversation today, I'm going to start with a very simple question to our panel members. And why are you interested in life after TB?
I've been nominated as the first. I guess the starting point for my interest in TB in general is that it's a disease with such great inequalities. I did my training in London, and I guess in the UK we don't see nearly as much TB as you see in other parts of the world. But what we do see is TB in really vulnerable populations, so homeless populations, people with mental health issues, substance abuse, new immigrants into the country. And when you look at low and middle income countries, you sort of see it in a more dramatic way. It's a disease of poverty. And so you're already dealing with an incredibly vulnerable population who are hit really hard by a significant illness. And I think if you look at what we've been doing as health services so far, we really concentrate on getting people through treatment, and we focus on microbiological cure and survival, but we forget about our patients' ongoing health, and we forget about the impact it has on their broader life and the life of their family and their networks of people. And so I guess my interest in life after TB comes from a place of saying this is a vulnerable population, and that vulnerability probably continues even after TB treatment is completed. So that's my...
Before I had TB, I was a dietitian, and I treated a lot of patients with TB. But then in 2012, I was diagnosed with XDR TB, and just the walk for those 2 years on the treatment was a nightmare, where I often felt like giving up. I often felt overwhelmed. So I kept looking forward to the World TB Day 2014 when I finished my 2 years on treatment. And then it was quite difficult to deal with the reality that, okay, I now have to find a new job, and that's some of the things post-TB that you are faced with. And I think if you're passionate about your job, like I was, being a dietitian in a children's ward, a part of my identity was wrapped up in my work. So you kind of start over, which is a good thing because you're free from the medication, but it's also a new thing. So I relied a lot on my family and friends to regain self-confidence emotionally. And then on the physical front, I had peripheral neuropathy in my feet, so it was very painful, but at least I had access to the treatment. And I think that links to what Jamila said. It also made me think, I've got economic access to good medical care, so I had expensive treatment for the neuropathy, and it helped me with my recovery. I could do physio, I could swim, but patients who were treated in public sector got the other treatment that's less expensive. And when I read the pamphlet insert, it said one of the side effects or one of the cautions is it shouldn't be used if you are suicidal. And we know how a patient feels. You are quite depressed when you're on TB treatment. So slowly it opened your eyes to what TB is like for the majority of people who don't even have food. So I knew what the disease was about. I had a lot of support. I had finished my treatment, but still the road was difficult. So I was saying to them earlier, when I had recovered, I was ready to hit the road and live life to the full. But like my physio exercise was literally like I had to lift my feet 10 times like this and repeat it 3 times, and I did that 3 times a day. So that's where I started, and I was in a swimming class with people over 80 years old with a physio, and once a lady in her 90s beat me, and it was like not good for my ego, although I'm not competitive. But what I want to say is that economic hardship is a reality faced by most people with TB, and post-TB disease, they should be given the right to health, and they should be included in healthcare decisions going forward. And I think that's why the post-TB lung disease issue is such an important topic that we are discussing. Thanks.
Thanks, Ingrid. And I think my answer is very simple. The reason I'm interested in the health and well-being of people after TB is because people like Ingrid and others who have survived TB and who represent the TB-affected communities have told me it's important. And I guess I recognise I'm in a lucky position, you know. I haven't had TB. I'm in a lucky position of being a professor of respiratory medicine at the School of Tropical Medicine. I get to be lung health director for the union, and I could spend my time doing something irrelevant like counting butterflies, or I could do something really important like working on this, and I've chosen the latter.
Hello, everybody. I'm sorry I was a little bit late. I was coming from another session. So my name is Tatem, and I'm an XDR TB survivor from South Africa. I'm also a physician, and I'm a public health practitioner. I'm currently specializing in public health. So why I'm interested in life after TB, it obviously started with my TB story. I was diagnosed in my community service year of my medical training, and I acquired TB because I was working in a mining community. And I was one of the fortunate people who received bedaquiline while it was still in the compassionate access program in South Africa. And for me, I've spoken to so many TB survivors, and I've heard the stories, and a lot of them have been very touching. What's very different with my experience is that everything was ideal for me as a patient. You know, I got TB at the right time. Had I had TB a year before that, I wouldn't have had access to bedaquiline. I had TB at the right place. This is in South Africa. So we had access to medication. We've got very good physicians. I'm lucky that I'm a physician. I've got a very engaged family and friends. I had all the support that I had. But the more I've engaged with other people who have had tuberculosis, I noticed that these people are going through hardships. I remember that the one time I was in hospital for 3 months, and you know, with patients, you just kind of sit around with each other, and you're bored, and you discuss, you talk about anything. You talk about the sun and the moon and the stars, and we're talking about, you know, some of their challenges. There were people from far away. I remember this one gentleman was all the way from the Eastern Cape, which is it's quite far. I don't really know in terms of length, but it's a different province, and it's quite far to get from there. And they hadn't seen family and friends in the entire time they'd been at the hospital, and they'd been in the hospital for about a year. They didn't have a toothbrush. They didn't have a simple thing like Colgate. You know, so it's the little things, and just noticing that people are going through challenges while they're undergoing TB treatment that really got to me. And other people were just uneducated about tuberculosis. Like, you're sitting in a hospital, you're here for quite a few months, but you still don't know what your treatment is about. And it just kind of got me asking myself about access to treatment. You know, there are lots of people who didn't have the kind of access to medications that I do. It also got me thinking about all the challenges that patients go through, how they lost their jobs. I had lots of friends who lost jobs because they're working in the informal sector and their work was not protected. Unlike me, who could take occupational sick leave and know that I'd still have a salary even though I'm in the hospital. So life after TB for me was trying to address all those other issues. It was addressing the access issues. It was addressing the support that needs to be given to patient. And that also kind of paved my way into specializing into public health, because a lot of this is about public health. It's about addressing social determinants of disease. And that really gave me the motivation to do lots of advocacy, to work a little bit more in the health system and try to address issues such as access, about addressing issues about quality of care, and about giving patients support throughout their journey of TB treatment and even beyond, because it doesn't stop to when you're cured of TB. It's about the rehabilitation as well. If you've had hearing loss, or if you've had, I was listening to Ingrid talking about neuropathy. I also had neuropathy. It's about going through those rehabilitative phases after going through a TB treatment and your TB journey. Thanks.
Yeah, I think I come from a slightly different perspective. I'm a clinician, fully trained in South Africa in a high burden setting. And from the time I can remember, earliest time of my medical school days, there have always been patients with post-TB lung disease around. And it's something that's been so obvious for us in a high-burden TB setting. So just to put numbers to it, there are over 350,000 cases of TB in South Africa per year. In Cape Town alone, which is where I work in the government sector, we have more than 24,000 cases of TB alone per year. So there are a lot of people out there who have had tuberculosis. And many of these patients, unlike other infections that occur in the lung, tuberculosis leaves its footprint, and it causes scarring, it causes damaging. Not in everybody, but in certain people. And as part of our daily practice as a pulmonologist working in a high burden hospital, a high burden setting, we see a lot of these complications ranging from airflow obstruction, very severe airflow obstruction in very young people, to people with severe bronchiectasis, and people are dying. They're literally dying at a very, very young age. And when you start looking into it and you start discussing it with your colleagues, everybody knows about it, but nobody kind of it's just swept under the carpet. And for years and years and years, for the last 150 years, TB has been focused on in terms of diagnostics, in terms of treatment, and that's correct. It's a potentially treatable disease. But nobody's actually looking after the respiratory care of people afterwards. And now we know that people survivors of tuberculosis have a shortened lifespan. And we now know that, and that's as recent evidence that's coming out. So we've got a lot of work to do. And in terms of how do we treat our patients, how do we manage our patients, how do we care for our patients in all aspects, not just medically, I can't avoid it. It's part of my daily work and my daily existence. And I think we need to take it from outside, from under the rug, and start putting it out there and saying, okay, so what are we doing for these people? Because there's been such nihilism in the medical community. They just said, okay, it's done, TB's cured, go on and enjoy a life. And nobody's actually looking to the quality of life and the respiratory function that people are having. So I can't avoid it. I can't get away from it for the rest of my career. I'm going to be dealing with it on a daily basis. So we need to start talking about it and get involved.
Thank you very much. So that's a little brief introduction. Just maybe to start, while people are in the room are thinking of any questions they might have for our panel, I will start with some of the questions that we have already received from those online. And just to say that those of you who may have tuned online, please do send in any questions you may have for our panel today on #LifeAfterTB. So we had a question that maybe I'll give you a chance to volunteer, but if not, I will nominate people. So the question is, what are the lung and other organ-related sequelae or after effects of people who have survived TB? So I think, Brian, you touched on it a bit, but I don't know if any of...
So I think the reality is that for a lot of people, there are no consequences. Maybe it's a bit of scarring, and people go about their normal life, and that's it. It's gone. It's done. It's maybe a little bit of a fingerprint left in their lungs, and that probably is the majority of people, to be honest. But there definitely are certain people who have quite significant damage from tuberculosis, and that can look like various things in various people. It can be range from mild to very severe, and it can be a number of subtypes. So, for example, some people might have very bad dilatation of the airways, or what we call bronchiectasis, and some may have damage to the small airways, much like emphysema or COPD. And some people may have scarring of the lining of the lungs, which we would call pleural residual, pleural thickening or damage. And there are lots of different complexities of this. So it can look like a number of things, and it can look like nothing as well. So it's a huge range, but there are so many people that are getting TB. 54 million people since in the last 17 years have had tuberculosis, that even if 10% of them have scarring, that's 5.4 million people with significant damage in the world.
Do any of the other panel members wants to add in?
No, I totally agree with what Brian has said, and I guess the other thing to add is that we think that these patterns of lung damage are associated with problems going forward, and there's a lot of studies ongoing to try and work out what those problems are. But it may be that people with significant lung damage have increasing rates of infections again and again over time. We think they may be at increased risk of getting TB again in the future. And as Brian has already said, we know that people who survive TB have increased mortality in the long term, and there's a question about whether lung damage, for those who have severe lung damage, whether that's part of something that contributes to that.
Thanks. And I think it's the lung is undeniably the most important organ in the body. But of course, I think there are other consequences as well that are important not to overlook. And I guess that psychological suffering is a big one that comes out very consistently, and I think is something that is very easy to overlook in people post-TB, but respiratory patients in general. So I think psychological morbidity, the social, economic consequences, the general health issues, including the consequences of hearing loss, the peripheral neuropathy we've heard about, renal dysfunction. So I think that, although quite rightly for a meeting like this will focus on the most important organ in the body, there are many other consequences, and I think it's that. I mean, it's one of the great benefits of working with TB survivors and representatives of the TB affected communities is that we think about the individual, but also the bigger picture. It's not just about the individual; it's about the family, it's about the community.
Thank you. So I think this is an opportunity to take questions from the room. If you are tuning in online and hearing some background noise, just to let you know that we are in the Sportthøyvedika area of the conference, and it's a very vibrant area. So just to say, everything's okay. So now I will take a question from the room.
Thank you. Is this meeting only about the lung post-TB, or can I ask other questions as well?
I can ask anything.
Anything. Yeah.
Okay, because one thing that troubles me a lot in the way that we manage TB is that the outcome is binary, either successful or not. And successful means that you're still alive, but that alive is defined in its crudest possible way. And we don't seem to give any urgency to the need to prevent morbidity before we start care. So one example which frustrates me greatly is that the WHO still has smear microscopy in its bag of diagnostics, even though it misses a third of patients. And any delays in diagnosis are associated with not only mortality but severe irreversible morbidity. The other aspect is this tolerance amongst care providers for severe irreversible side effects amongst patients, as long as we keep them alive, right? So my wife was told deaf or dead. That's a popular refrain for many people. I know two nursing colleagues, one has passed away after surviving TB from side effect related problems, and the other one is currently in hospital. She won't mind me mentioning her name. Sister Pat Bond, she's been in and out of hospital repeatedly. They both suffered at the hands of the old NDR treatment. So first of all, we should not have such a high tolerance for waiting and allowing the disease to progress, and secondly for prescribing medicines, particularly in the presence of alternatives that cause devastation to patients. And then the third component is what can we do for patients that have already suffered, for whom there are clear rehabilitation opportunities. So when I first met Pumeza Tesile, I was blown away by the character and the quality of the activist. But after I met her in Paris, she went back to her shack in Khayelitsha, socially and economically excluded. And it's only after she accessed cochlear implants, she's now can't be with us today because she's writing a final exam, second year of gender studies at the University of Cape Town, and she accessed a very prestigious bursary. Same story last year. The most inspirational talk by far at the United Nations high-level meeting was from Nandita. And again, in the opening ceremony, a dancing performance, and it's tragic because she can't actually hear the music that she's dancing to. And such a high-level activist, surely there should be ways of giving them the gift of hearing back. So I'm going to leave that there, but maybe if this can be a project, the first project for the post-TB group is to give activists like Nandita a second chance at life.
Very much appreciate the call to action, and I guess that, you're speaking our language, of course, and we're speaking yours, and I guess the outcome should be health, not life or death. I don't know if anyone else wants to pick up on what can be done post.
A strong theme that's come out in this, I mean, not just in this week, but before, is that should we be only looking at time to positivity and smear microscopy return? That's what you're saying, you know? And this is not the first time this exact situation has been looked at. And we need to advocate for other outcome measures in our TB drug trials. You know, and as I was saying this morning, if you are comparing two drug regimes against each other and they have equal time to positivity, but one gives you with a better set of outcomes, be that in terms of side effects or in terms of lung preservation or in terms of something else like that, you obviously have to choose regimen A, not just say that they have the same time to positivity, choose whichever one you want to. And that needs to be done at a very high level. And you're absolutely right, because that needs to be, the funders need to say in their protocols, it's not just about time to positivity, it's not just about are you alive or are you dead, it's also about which drug is actually helping you to have the best quality of life afterwards. And equally, we need to be assessing our patients afterwards. As you know, when you finished your TB treatment, is it ethical in this day and age now, with this movement in the post-TB, is it ethical to finish your TB treatment and to not assess your patients and to not say, okay, let's have a look at you. You are left with chronic lung disease. You need to go into continuing care. We need to do everything to fight for your lungs and preserve your lungs. I'm talking from a pulmonologist. The same for any other organ system. But as a pulmonologist, you know, whereas other people don't need to be institutionalized, or they can go on and have a normal life, you know, and we need to, is it ethical not to be doing that? And that needs to be, that's a real project for us as an advocacy group to get that right.
I think all of us in the room who saw Nandita would feel like, wow, this really made an impact, or this moved me. And basically, from a health systems point, it does need strengthening to help people post-TB. I totally agree. But I also think the involvement of other key stakeholders is key, because if I can use the example of our Mama Scroll Community Health Worker TB Champions, I am a TB survivor, so I am very much for community involvement. Yet, when we went to the community and they were struggling with stigma, we thought the solution was to go and talk about TB and stigma. And after our talks, the community health workers would come on the stage and do a little drama play. And that happened every time we went to the community. And by now, we have a drama director directing their drama plays, and the community feedback has been that they don't want to stigmatize people. They felt sorry for that character. How can people be so mean? They want to be kind to their fellow community members. And it just goes back again to messaging. And when we're talking to our patients about post-TB disease, saying something in a way that the patient understands you is it's not something to tick off, part of an algorithm. You know, with the first session you explain that they have to post-TB be followed up. It's actually really making sure that our messages are tested in a scientific way, so that the community is involved with that. And through that process, a local TB champion being funded could be used to make sure that the TB program runs better and that it's implemented, because a guideline or policy won't work because if it isn't being implemented and supported by the local community. So I think having like a partnership from the beginning would be great.
You know, Arne, actually you brought up a lot of things, but I think I just wanted to focus on one specific point that you spoke about, and it's about how we have that binary approach when we're managing people who have had tuberculosis. So coming from a medical background itself, I know we are bombarded with having this very clinical focus when we're treating a patient. And yes, it's been changing, and medical curriculums are taught to look holistically at a patient, but it doesn't really seem to be translating well into how we manage patients, people who have been infected with tuberculosis. So I spoke a little bit earlier about, you know, one of my focuses being how do we rehabilitate people who have had TB back into communities and stuff. And it's very difficult, because if we don't know what the issues are, then how do we rehabilitate it? So one of the things that I've really been speaking about when I go onto platforms such as this and international platforms, when I go to speak to the WHO, is starting to, you know, to address and raise awareness about the issues that patients who are living with TB have had. Not just the clinical issues like, you know, the lung complications and stuff, but it's also the social, the psychological issues. And I think the one the one key issue that I've been able to address is the catastrophic costs the patients are undergoing. And I think that's probably where it starts. If we start raising and being very loud that patients are undergoing all these challenges, then we can start maybe having proper discussions on how to address them, including the patients in treatment care plans and making sure that the treatment care plans are holistic. It doesn't just end with cure. I'm thinking if you're maybe a diabetic and a surgery is planned that you need an amputation. At some point in time in your continuum of care in the hospital, somebody's going to speak to you about what's going to happen about after when you have your leg or your foot or whatever amputated. But it doesn't happen with tuberculosis. And that's the kind of shift that we should have, that there are sequelae that could happen once you're done with the TB treatment. And this is how we're going to help you address them. And I think that's the kind of focus that we should have with our care as well. Yeah.
So I think maybe, some of these I think has already begun to be addressed, but really to take some of the questions that we've had from online, and there is a very common theme. So I'm going to merge the question from @Ria Lobo and @Nandita Verike, and that's really that how do people get their lives back after TB? Sort of what is back to normal post-TB, and how can we support that in best we can? And so maybe, I think I'll leave it to the panel to think about how we answer that, but I think maybe it's the medical and the psychosocial, psychological, but I will hand it over to our expert panel.
No, I was going to say that I think, I actually think that it's the experience of someone who's been through it that's maybe the most valuable way to answer that question, and I think it will vary from person to person, but really from a research and clinical perspective, we see such a limited portion of what life after TB is in reality for someone who's been through it.
Maybe a starting point would be to open the platforms and ask people, what do you think would make your life or the transition to normal life better again? In Scroll, when we asked that, people said that more support, whether it's in a TB support group or just from their family. So it seems like the psychological support is the strongest need. But I suppose like Jamila said, if you were affected more in a physical way, you would need rehab. So then maybe it's a human resource issue where there should be more social services and physiotherapy so that patients can be seen regularly in public hospitals. So I think it's a great question, and it's something that should be asked to a wide community of TB survivors.
Yeah, I agree with Ingrid. I mean, it depends on your setting, it depends on your experience, it depends on what what your treatment journey was about. What my needs may be different to another person's need. But I think the truth is that we haven't had the conversations yet. We haven't spoken to the people who need the support, so we don't really know what kind of support is needed. We know patients need support. We know people who have had TB and their families. It's not just about the person who's had the TB treatment. It's also about their families, because it's a community disease. It doesn't only affect the one person. But really, we haven't given people who have had TB an opportunity to actually speak and say, I need this kind of support. We know support is needed, but we need to identify the actual kind of support. What are the practical things that are needed? What are the resources that are needed? Do you need me to direct you to an actual center that will help you with A, B, and C? So we really need to get down to the actual issues by sitting down with people who've been infected with TB and finding out what the actual support is. Yeah, because I don't think it's like a cookie cutter. It's not going to be a one size fits all. It may need to be tailored to that one individual in terms of the kind of support that they need. And it's interesting. I was speaking at a session yesterday about individualized treatment and individualized care. And this is the kind of individualized care we're talking about. It's about sitting with an individual and seeing, what does Tato need post TB treatment, and helping them get through their life after that.
What you've just said resonates extremely well with the discussions we had at the recent first international symposium on post-TB, where Ingrid and many others from TB Proof spoke about the need for some guidance and the need for evidence to inform what that guidance should look like. And actually the first thing that's needed in terms of the research evidence is understanding what the patients need, like you're saying. So that's, and I guess that's something that people on this panel and the wider group at the union are, that's what we're expert at, is doing the research to answer those questions. So I think we should take that on as a call to action there, and do that work starting with listening to what people who are going through the experience need.
I think we have another question in the room.
Hi everyone, Goodman Makanda from South Africa, XTRTB survivor, living with a lung. Thank you. I don't know, it's a comment or it's going to be a suggestion. I'm worried of you talking of the last stage. Me as a community, as a person living in the community, we still have a challenge with the counseling when I find out I have a TB. So do you think how you going to get them if the level surface is not being prepared? So you talk about the higher level when I finish a treatment. How many will get them finishing a treatment? Because we're struggling here. I was doing getting a counseling by a person been trained as for HIV. When I talk about TB, she don't know or he don't know nothing. So to talk about the last stage, I think to me it's the last stage. Yes, I understand it's a pain also to me, because when I applying for a job, I must explain who I am. I can't work to the fridge, I can't run, I can't do that because of TB. And the labor people, they see I'm a useless human being. Yes, I understand it. But I still have a problem with the surface where we're supposed to build them. A structure, a right structure, so we can accompany and hold their hands until to the after TB, after life with TB, whatever you put it. But I still have a problem here. How are you going to do it? How are you going to build to get what you're talking about? Because to look for, to get something, but you, underneath is still a gap. We still have a gap. A counselor is trained for HIV, not for TB. When I talk about linezolid, I have a problem with my eyes. And then no, I don't know. I only know ARVs. That is, ARVs make this and that and that. We don't have a room as a TB patient where we can express ourselves when we are on a treatment. So can you clarify for me the structure you're going to build on what you're talking about? I'm asking you and begging you, let's start from the level ground, build a right structure so we can get a good result. We will see later when I finish a treatment what you're going to do about me. Thank you.
Goodman, I think your experience working with peer support groups is very valuable. And on that point, what do you think would help people to understand and motivate them to complete their treatment, or support them to complete their treatment and to come back? Is it a relationship with a clinic, or is it more in the support group? What do you think is the priority to focus on to build that trust?
You talking with a person, I start my own support group, but I end up stopping it because of financial I was taking out of my pocket. But we have a good result with MSF. As you can see, MSF in Kailija is counting high rate of people being cured with TB. It's because of a support group. What I think in our community, we need to be more engaged with the community level, because we have a problem. Always saying when I talk with the researchers, don't do it for a community. That will be a big mistake. Do with. If we work together, we can conquer TB. But now, as talking as a person, I'm doing a voluntary job at a clinic. When they diagnose someone at a clinic with MDR TB, and then I lay a foundation to say you're gonna face the challenges. So talk one-on-one with a person, understand the journey you're gonna go through. So when you face the circumstances or obstacles along the road, and then you will say, no, that person, she did or he did tell me I'm going to to face this challenge, but I will pass it. So to a work relationship specific, let's not combine HIV and TB. That is a big confusion. TB must stand alone, as HIV it was standing alone. No one with HIV was talking about TB, but we have a problem of saying TB and HIV, they are sisters. I'm not against that, but as us people living with a TB, we never have a good therapy. We don't know where to go. Thank you.
I could have a go at responding a little bit to something. The bit about what the structures look like, I think we don't know, but we need to know from people like you what you think they should look like. And I think that speaks to the point about the research that's needed here is, first of all, to understand the needs and then build from there. And I think the other point, I think one of the points that you are making is probably that there's life during TB and after TB, and there isn't a sudden point at which you're after TB and you're before TB. There's life throughout. And I guess one of the reasons that we're framing this discussion today in this way of life after TB, and while we've got a theme of the Union, which is health and well-being after TB, is because that phase has been completely neglected. We've heard that repeatedly from TB survivors, TB affected communities, that moment where the binary outcome has, you're alive or you're dead, is where the interest stops. And so I guess that although it is artificial to do this, it's deliberately advocating for, well, don't forget that long, hopefully, bit of life after TB, and let's advocate for doing and do some research that will make a difference to that phase of life as well. But of course, it's a continuum, and it's not, it's a little bit artificial. But I think it's important, just where we are at the moment, to focus attention on that neglected time after TB treatment's completed.
And I think as a medical community, and we need to acknowledge that we are very bad at looking at the non-medical needs of patients. You come in with a cough, you get an antibiotic, you go home. There's nothing else to it. There's a long queue of people, and we need to acknowledge our weaknesses in that, and we need to try and leverage off people like yourselves and other communities and build it into the system, which is difficult, but it needs to be done. And I think that, as you've already said, the first point is to listen, and to listen to hear what is needed and what is said. But we need to acknowledge we're not good at this, and not many people are, but that's not an excuse not to try.
Thank you. So I think we had a Twitter question from @Nella Mukagoni, which was very similar to that. And then she had a follow-up question, which was, how can we ensure that cured TB, people cured of TB are not reinfected? Is there anything particular we should be doing on that front? Any volunteers for that one?
Okay. So it's very well known that people who've had tuberculosis are at increased risk of getting tuberculosis again. And this is becoming more and more evident, and it's becoming the people, the TB survivors are an important group in themselves for the whole NTP program. And what we are not doing as any NTP program is routinely following up people to see if they have TB again. And we know that in the first year or two, you're at particular risk of getting tuberculosis again. And we've had lots of discussions, and there's some people that have done modeling work on this, looking at the impact that this may have on the entire TB epidemic. And it's a bit of an academic answer I'm giving, but the point is that you are at risk of having TB again if you are a TB survivor. And so you need to have a heightened sensitivity. And as Ingrid, I think, pointed out in a previous session yesterday, just because you are a TB survivor and you now have a new cough doesn't also mean that you have TB again. You might just have an infection of bronchiectasis. You don't have to avoid the system worry that you've got TB again. There are other diseases that it can be. Equally, if it is TB again, you need to be diagnosed quickly so we can get on top of it as fast as possible so that you can return to normal life as fast as possible. So it's a difficult question to say, how do you avoid it? We don't know the recipe to avoiding why some people do and some people don't get TB again. But that's an area that we need to research. We need to find these answers for people.
I was also going to say that's a very difficult question. How does anyone avoid TB? Essentially, we know this is an airborne disease, anyone is at risk. But I think, from a person who's had TB, we could maybe just start with people that we know are at higher risk as well. We've got lots of comorbidity, especially from where I'm in my country, in South Africa. So maybe we could also just start with people that we know are at higher risk. We've got co-infection with HIV. We've had lots of studies that have showed that people with diabetes are also immunocompromised, smokers. So maybe we could start small if we need to be. We know that not everybody who's had TB will get reinfected again as much as they've got a high risk, but we know there's certain populations that are even more at risk. So I think it's taking the first steps and building from there until we have progressive realization of just ensuring that everybody's prevented from being infected with tuberculosis.
Any questions from the room? Okay, we've got a question there at the back. Don't know. And just while we're getting the microphone, if you are tuning in online, remember you can still ask questions at #LifeAfterTB.
Hi, I'm Andrew from Canada. It's not really so much a question, just as a comment on the difference between TB treatment and HIV treatment. So before somebody's put on ART, guidelines tell you there's several stages a person makes a decision to go on ART. Now in TB, it's required to be treated or isolated if it's infectious. In HIV, there's a pre-contemplation stage where people are saying, do I need this? And you need to support them and respect them, provide them information about the treatments. There's a development of a treatment plan where it's an agreement that the patient knows and has information about all the effects of the treatment and what would happen. There's a mutual respect there and a development of an agreement about the treatment. That doesn't really happen in TB, so I just was saying that TB programs could learn a lot from HIV programs in terms of that respect. And maybe not assuming that they have to take treatment is a good way to start. That you can. So hopefully that's not off topic. I came in a bit late, but just thought that's an important thing to look at.
Can I just, I think that's a very good point that you raise. And just looking back at the HIV epidemic in South Africa, the lessons were definitely there. Before you had an HIV test, there was proper, thorough counseling that the person knew what they were getting themselves in. So we certainly could learn a little bit more from the HIV epidemic. Yeah.
Great. So I've got another question from... Oh, okay. No, we'll go one from the room.
Thank you very much, and thanks. I just wanted to raise something around the post-TB. In most of the union meetings we come to, you see this very strong activism from across the globe. People are really very powerfully making points about how government should be engaged, how international organizations should come in, academia, research. And I'm just, after listening to the story of Nandita, and some of us actually shed tears. He had to take someone going to court in her country to get them to do something. She lost her life for other people to be taken care of. So I wanted to know what's happening within our countries. I worked in pneumococcal vaccine for a while, and when Wyatt was the only company making PCV7, and they did the first trial in California and had to stop it because the efficacy was so high, and I decided to make things happen. But the burden of pneumonia was in Africa, Southeast Asia. So it came to a point in which there was no way we were going to make any progress if other people don't start manufacturing PCV7. So we had the vaccine, Pfizer took over another, but then Brazil was making it, I think India, and it just became available. So what are the countries, India for instance, and my country, Nigeria, how much of this activism is going on in country, if possible to arm twist our policymakers, our philanthropists, to actually go into, for instance, can bedaquiline or delamine be made by some local company? I don't know what the rules are. And then some philanthropists in country will pay for it and say, we've got 1,000 MDR patients. It will cost us $10 million and we want to pay for it. If we don't go that way, if we don't include that bit, we're going to waste our time. We are going to make some achievement, but it's going to really be very, very slow. So, I listened to colleagues from South Africa. It's really, I was with Ingrid, and I've listened to a number of other people, and they talk about, how lucky, if you like, or fortunate they were to have survived, and the issues around when the drug was allowed and all that. What's really happening in country, outside of our meetings like this? I know in my country, absolutely nothing, and which is shameful. But what's really happening, because I think that if countries come into it, like India has done, in saying in 2025 we want to get rid of TB, and we're beginning to see investments. What's really happening in country to complement the global efforts, if anyone knows?
Thanks, Uzo. I think I can't answer that exactly, but I think what we've learned was that relationship building takes time. So it's almost kind of getting that first contact between a person from civil society affected by TB with a policymaker. Because like you said, you were moved to tears when Nandita was on stage. But if those people are never in the same room, it's very difficult. I can't actually see a way where you'll make progress with advocacy. And the second point that I think we've all learned is that maintaining and building relationship should be the goal of engagement over the long term, because in a sense we don't want to work, you want to address points that the government or Department of Health are wrong and make it better, but at the same time we have to work together, because otherwise we're actually just complaining. So I think advocates' jobs are kind of to be creative in finding solutions, working with communities, because the solutions are there, and also coming with an opportunity that would interest policymakers.
I just wanted to add to what Ingrid said. So I was going to say, with the example of South Africa, I'd like to use that example because that's been my experience. I think as an activist, we've also been very strategic in how we engage with our policymakers. For example, if you look within TB Proof, which is our organization, and you look at the different positions of the members of TB Proof and where they're active, we've collectively, by using the little powers that we have in our little spaces, we've been very strategic to trying to engage with our policymakers. For example, I sit on the WHO Strategic Technical and Advisory Group for the Global TB Program. Ingrid is involved with the union and a whole bunch of other boards and platforms. We have academics, we have researchers, we have people on the ground, but it's just about using our collective powers and interests to come up with a strategic way to engage with our policymakers. Also ensuring that we've got the relationship, we've got the trust with them. For example, today we're able to go to our minister or go to the senior politicians and the decision makers and actually engage with them in conversations about what we need as a community. And it does take time, but it's steps. I got into advocacy from 2014, and it's taken time until we've realized an injectable-free regimen in South Africa. So it takes patience, and it takes strategy, and it takes the collective powers and the opportunities and the skills and the information that we have in our communities to do so.
I was just going to agree, and I think forums like this are particularly helpful in that you've got clinicians, academics, advocates, communities, policy workers in one arena. Ingrid, you were saying that it's the role of the sort of survivor in a way to advocate for things to be done, and I guess from a research perspective, it's our role to provide you with the evidence and to provide policymakers with the evidence to support action. And I think in the post-TB field, really what we have to be very conscious of is that we're at a point where we need to generate that evidence and make the case that something needs to be done strongly.
So I'm just going to take a question from online, and then I'll take one from the room. So this is a question from @Taberk, LOL. Sorry, I'm not. As I said, I'm a bit of a dinosaur. And this is, she says, I've had pretty severe lung harm from TB, but luckily all in one. And my biggest concern is living as best as I can on one good lung. So my life after TB question is really, how do I do that? I already get the flu shot. I've never smoked and I will not start. I hate exercise, but I try to do it. But what else do I do? Am I missing anything?
Don't smoke.
A room of
Don't smoke
pulmonologists will
anything.
always give you that answer.
Yeah, I think it's a very good question. I mean, many of the things that you mentioned, I just want to highlight a couple of them. The flu vaccine, annual flu vaccine is a very good thing. The pneumococcal vaccine every 5 years is a very good thing. We know that those things work in many chronic lung diseases, so that's the first step. Exercise is very good. We can show that rehabilitation. I think you've got to run your first half marathon if you can, and that is. I'm being a bit facetious. It doesn't have to be that level of exercise. They say 45 minutes of brisk walking 5 times a week is a good level of exercise. But the more you do, the better, and we know that. Outside of that, I think you have to look after your lungs. And what I mean by that is when you feel like you're having an infection, make sure that if you need antibiotics, you get tested and treated quickly. Don't wait maybe that couple of extra days. That would be the one additional piece of advice that I would say. If you have a syndrome like a bronchiectasis syndrome where you have daily production of sputum, you may want to seek help with a respiratory therapist who might teach you how to clear those secretions. That also might be something else that you could add. And then there are other, depending on which clinical syndrome you're left with, if you are left with a clinical syndrome, there are other things that you can use like bronchodilators, etc., which will help you maybe to avoid the odd exacerbation, maybe also just to increase your exercise ability a little bit. But it sounds like you're doing a lot of the right things, and I'll just say again, don't smoke.
I guess the only thing I'd add is that if her symptoms get worse, don't be afraid of testing for TB again. It's really important to not be scared of that. If it's there, the sooner we find it, the sooner we can treat it.
Great, and we'll have another question from the room.
Thanks very much, and sorry for coming in a little bit late, but I just wanted to say, one, it's a fantastic panel, and I think in a lot of ways, like your comment just before about the fact that as medical professionals we need to get better at dealing with non-medical problems, but equally the gentleman over here's point around what is actually happening at country level. I think that there's a connection here, and it's this particular thematic area is really important for bringing it out. For a long time, I think we've tried to reframe TB as not just a medical issue and not just a TB issue, but it's something bigger. And life after TB is maybe a really great example of how we can reframe this as a broader issue that needs to bring in a lot more stakeholders, because whilst this conference brings together all those people who you described, there's maybe a lot more who can be effective in really being the game changer that we need to end TB. And equally, whilst there are lots of things happening in country level, we need to get better at maybe selling them, talking about them and promoting them, but equally acknowledge that a lot more needs to be done to build on it. But I'm just interested if the panel has any reflections around this particular theme of what you've been discussing, and how it could be something that could be used for maybe like a broader change in the way we think about a TB response.
Yes. You've got a longer answer to the question.
I have this dream where we get... I have a dream. So I have this dream where we get a group of people who've been infected and affected by tuberculosis, and we actually just sit them down and say, if you had to do this your way, how would you get it done? How would you have your treatment? What kind of support would you need? And maybe start from there. I'd love to see more patient forums, more patient focus groups, where you actually just speak to the people, because that's really how we're going to sort it out. And that way we can raise an awareness. We have researchers, we have amazing researchers who've got an ability to just put that information together in something meaningful. We have people who can translate it into communities and broadcast it on platforms like this. So just get people in a room, get patients and people who are affected by tuberculosis, and let them tell you what to do, Just
to add to the complexity of what you're saying, we often talk about, there's a theme in the medical world at the moment about communicable and non-communicable diseases and the overlap. And there can be no better example in the world than an infectious communicable disease turning into a non-communicable chronic lung disease than tuberculosis. Other diseases do it, clearly, surely. But this got to be one of the most important ones out there. TB is the number one infectious killer in the world, but nobody's talking about the chronic lung disease. And I think just not a solution, but just to add to that, we need to have a shift. We've had certain meetings this week where people have said, well, where are you going to put it? Are you going to put it in the non-communicable portfolio of our country, or are you going to put it in the communicable NTB program, which is where there's two silos of care, and yet this doesn't, people flip-flop between the two, and that artificial barrier needs to be broken down. And the one adage is the squeaking wheel gets the most oil, and if you're not making enough noise, it's never going to happen.
I'm going to use a bit of chair's prerogative actually here. I mean, I think it's a great question, and the NCD and non-communicable and communicable disease. I think this is where, if we look at the environment we're in this year with the UNHLM on UHC, and I think this is where we need to make a really big statement to countries that TB should be the cornerstone of their UHC planning. I mean, I think in a lot of countries the TB program has got down to the lowest level of healthcare. They may still be offering a microscopy, but there is a pathway of care that is present there. And that is an interaction with the healthcare service. And we know that TB isn't just you get diagnosed, you get cured, thank you very much. And I think we need to think about, is this a way that we take the systems we have and broaden them out such that people who have TB are at the center of offering a universal approach to healthcare, both before they have TB, so that we have that platform that we're offering a good service. We're taking the risk factors down. We're looking at nutrition. We're looking at diabetes. We're stopping people smoking. We're making sure children are vaccinated and are well nourished. All these things. Then if they do get TB, we offer them the best standard of care, and then we take care of them going forward. So I think while the political attention is moving away from vertical programs and a universal healthcare approach, we should think in TB of how we make that argument that we are the basis of what UHC should be built upon. And I'll now be quiet and go back to chairing. So, Ingrid, did you want to add anything?
No, James just made me think, the first time that I heard Kevin present his vision or the strategic plan for this, and I was just reminded that sometimes we start with programs, but the strategic planning is also like a massive thing. So the more people who are interested in it to work on it, and the more people who give input, I think the better the outcomes will be.
Yep. Another question in the room? Yes, at the back. We'll just bring him a microphone there. Thank you.
So I'm coming from Delhi right now, and Delhi is it's become a gas chamber. It's so polluted. The air quality index is above 400, above 700. So I wanted to ask, in terms of availability of clean air, is there any data on how much is TB exacerbated with air pollution? And should we also discuss TB in the context of air pollution while we discuss TB in the context of malnutrition and poverty and such?
I'll have a go. We had a plenary this morning about deadly air, and Sandeep Salvi from the Chest Research Unit in Pune, India, presented data suggesting that the air pollution contribution to the risk of TB is high. I'm not sure how robust the data are, but I think that, and of course, one of the problems with the field of air pollution, I guess particularly household air pollution, is how entwined those issues are with issues of poverty and therefore the underlying risks of TB. But I think in a way, so making the link with TB could be very helpful, and certainly there have been some attempts to do that in terms of household air pollution and TB. There are data from Nepal showing an association between kerosene lamp, paraffin lamp use and the risk of TB. But at the same time, we've got plenty of evidence that breathing dirty air is extraordinarily harmful. So we already know that some 7 million people around the world die every year because of known associations with ambient and household air pollution. So we've already got a big number there. Further research showing that there's an association with TB might make that number even bigger. But I think that it's a very good point, but I think that actually, even as someone who likes doing lots of research on lots of different things, actually there's time to act. It's time to act and clean up the air, both for people living in poverty who tend to be the people exposed to most household air pollution and therefore the most risk factors for TB, and those of you living in these big cities like Delhi, where the kind of levels of exposure to air pollution that you're experiencing and in Hyderabad as well, they're not healthy. They're leading to strokes, heart attacks, COPD, pneumonia in children. The solutions there, though, I think sit much less in the domain of those of us sitting on panels like this and doctors and researchers who are well positioned for documenting the harms and documenting the risks. But the solutions do lie with policy and decision making, and I guess then in terms of individual behaviour, because all of us have contributed to climate change getting here, and the individual choices that we can all make as well. But I think most of the solutions to at least the ambient air pollution issue do lie with governments, in my view.
Great. Okay. So just a reminder that any of those who are watching online, there's still time to send in your questions at #LifeAtTB. So now, as we're getting a little closer to the end, I would like to ask the panel, what actions would you like to see in the area of life after TB in the next 5 years? So we sort of talked about it's been neglected. We have awesome people here on the stage and lots of interest in the room. So what are we going to do in the next, what would you like to be seen done in the next 5 years?
I think organizations like TB Proof and Stop TB Partnership, GCTA, TB people want to just show that people affected by TB want to be part of a community. So using that as a strength to engage with policymakers, I think is quite an easy way. But in the next 5 years, I think if each parliament has an advisor from the local community, part of the health ministry, that would be great. But this is like in a very ideal world where there's room for more parliamentarians, because a lot of the policy implementation or a lot of legislation is still needed to move forward.
I can add something that I think, so being realistic, what would be, not that that's not realistic, but 5 years will go by very quickly. And if you think about, we've talked about the need for some evidence on which to base knowledgeable decision making and advising policy and decision makers, and then having an impact on TB programs and universal health coverage. But the reality is that in order to generate that new knowledge, well, we need research grants, and research grants take a good year or two to develop and win, and then implement projects and get some evidence. So I think something that would be realistic is to say within the next 5 years, wouldn't it be wonderful to get a big grant that perhaps the union is a big part of it, together with TB-affected communities, organisations like TB Proof, that allow us to generate the evidence to then be able to advise on what is effective and what's cost effective, and what should ministries of health therefore justify to finance ministries that they should invest in, and what should the TB programs do. So I think if in 5 years we could give that share that information and then advocate for what we know is clinically and cost effective and acceptable and beneficial to those TB survivors, that would be my hope for the next 5 years.
I guess for me, sort of feeding into what Kevin has said and what Ingrid has said, is understanding what people's needs are for the post-TB agenda, both from a patient perspective, but also from national TB treatment programs, from health ministries, from communities. I think a real sort of thorough understanding of what everybody is concerned about, where people see opportunities, where people see barriers, and then once we have the evidence of what needs to be done, it will put us in a really strong position to do that.
Can I be idealistic in contrast to Kevin's realism? How many ideas am I allowed? Is there a limit? I think as a clinician, I want solutions, and I would like to see the initiation of trials looking at stopping or limiting the damage during tuberculosis. So is there something that can actually limit your damage? Going one step backwards, I'd like people to start assessing patients properly at the end of treatment or shortly after treatment, to look to see what the residual damage, not on a community level but on an individual level. So for this patient in front of you, what residual damage do you have? How can we advise that person, just to make people aware? And on the other side is when I'd like to see trials being initiated looking at how we're going to manage them. What is the best way? What is the best therapy for the people who are left with damage to actually preserve their lungs and maximize what they have left? Lots, and that's just the first 5.
I think just to try and not repeat what everybody has said, because I've already touched on what I was going to say, but it seems we need more evidence, we need more knowledge. So with the evidence and the knowledge and the research that needs to be done, we need the funding. And, where are those opportunities? Where's the funding that will come up with the information that we need? And that's probably what we need in the next 5 years. Find the funding, do all the research, understand what patients need. Yeah.
Any questions? Okay, we've got one more. Okay.
Yeah, here we go.
We've lost the microphone.
Thank you. I'm Ravandi. I'm an infectious diseases doctor and TB researcher and member of TB Proof. I wanted to follow up on one of the things that Brian said, and apologies if I missed this before, in terms of the evaluation of patients during treatment in terms of pulmonary function testing and ways to kind of triage who is going to do more poorly from a lung standpoint. There's also, I think, interesting research in the host-directed therapy realm. And so one question is, how do you integrate these services that exist in terms of pulmonary function testing, and like you were saying, so between infectious diseases and non-communicable diseases, and also thinking about what the role of surgery is and when and how to do that and building the capacity. And then on a separate note, I know that everyone on the clinical side of the panel is a pulmonologist, but one of the other aspects is extrapulmonary TB, and so other areas of disease like reproductive tract TB that obviously have a massive impact in terms of the stigma, the reality, the lack of data and understanding of that, and thinking about how to incorporate that into a post-TB agenda would be important too. Thanks.
I could do the last bit, and then I could, if that's... I completely agree, and in fact, within the strategy we've developed for lung health for the union, we've deliberately called it health and well-being after TB. So it's not just about the lung, even though the lung is the most important organ. But actually, we've got a post-TB lung disease sub-theme. We've got a general health theme. We've got psychological well-being, socio-economic well-being, really to recognise that it is there is a whole person at stake here, and so we're very much, although with much of the discussion, as you quite rightly point out, you've got 3 pulmonologists sitting up here. We tend to go back to our home organ, but we are very conscious of the other dimensions, and I very much hope that we're going to keep focus on those. And I think the involvement of the TB affected communities and survivors are helping make sure that we don't lose sight of the bigger picture.
Yeah, we are vaguely aware that there are other organs in the body. No, I'm joking. At the post-TB symposium, what became very, very clear is it's not just about the lungs. It is very much about the heart, the brain, every other organ system. In fact, the only organ system I've never seen TB in is the pancreas, I must be honest. I've never seen pancreas, but every other organ system I've seen affected by tuberculosis. And so your questions are very good. And the question is, how do you meaningfully assess patients at the end of TB treatment? And also, what is the best time point? Because is the most convenient time point is when you get your certificate of clearance at 6 months. That's the most convenient. But it also might not be physiologically the best. Physiologically, the best might be 6 months or a year afterwards, actually. And also, what is the best method of screening people for post-TB lung disease? And that's very much going to be a resource-based question. Are you in Massachusetts, where you do PET scans on everybody at 6 months after TB treatment, or are you somewhere which doesn't have an X-ray machine and a spirometer? And we can't make blanket rules for everybody saying you have to have X, Y, and Z when everybody knows it's never going to happen. But what our burden as researchers to do is to try our best to figure out what tests are the most impactful, even if it's a clinical symptom screen, what we can be implied and what is the minimum that we should be asking going forward. But I think even by just putting that one step in your NTP, assess patients for chronic lung disease at the end of TB treatment, you've already focused people on the fact that life does not end with the final tablet. Let me restate that. You focus people that tuberculosis does not necessarily end with the final tablet, that it may go on after that for many people, and it affects them, impacts them.
So just to follow up on Brian's comment, and someone else has made a point about this as well before about, well, why don't we just get on and do something? Why don't we just get on and make recommendations, even though we don't have the evidence at the moment? And I guess that for me, the big reason not to do that, at least in a blanket way, is, well, thankfully some 8 million people survive TB every year, right? And then if you think, well, any intervention that's added to that program is going to cost resources that have to come from somewhere, and you can bet they'll come from the TB programs. And so whilst there are lots of things that we would very sensibly recommend, like you did earlier in terms of vaccinations and self-management plans and antibiotics and maybe chest x-rays, and what about spirometry, what about a follow-up in 6 months? But when you start costing that, well, you're not going to get much for $1. It must be about $10 or maybe $100 per patient. And then you start multiplying that by 8 million people, and you're actually really eating into something, which is why I guess I would bring us back to what we've all been consistently saying about, well, we've got to get the knowledge so that we make wise recommendations. There's a big unmet need sitting out there, but we need to be really careful in terms of what it is that we recommend to make sure that the use of resources is appropriate and doesn't take away inadvertently from something that is extremely effective and goes into something that, as it happens, whilst it was very logical and very sensible, wasn't effective. And there's been lots of examples of that in history where there's been some very good ideas, seemed very sensible, everyone's charged in that direction, yet in fact it hasn't helped at all and has just taken resources from effective interventions.
I think we've got one more question in the room, and then...
Thank you. Hello, everybody. Good afternoon. My name's Ilsa. I'm a paediatrician working in London. I'm also a member of TB Proof. I just wanted to try my best to pick up from something that Goodman mentioned, which was ability to work after TB has affected somebody and has caused disability. This is obviously part of the sort of associated, so-called catastrophic costs associated with tuberculosis. And I totally agree with the need that we need to further understand what disabilities are associated after tuberculosis and gain more knowledge of that. Totally in support of that. But there will, of course, be a proportion of patients with, even with, maximal medical intervention who won't be able to be totally rehabilitated, and even during the period of rehabilitation will be unable to work. And I think Goodman's words were profound, and I think the word that he used was actually useless to society. So I think I've quoted that correctly. So that's obviously a part of the stigma associated with not being able to work and contribute to society because of the disability associated with TB. So I don't know if I really have a question, but it's obviously a massive problem that we need to address somehow. And I'm just wondering if anybody had any thoughts on that.
Whilst not having the solutions, we have deliberately in the strategy that we've set out included the word stigma and discrimination and disability partly because Ingrid told us to put them there, but partly because we listen and agree, and by hearing that kind of feedback and making sure it fits within our strategy means that at least we've got something to work to and start to address. So we hear those calls to address those big issues that sit outside our natural comfort zone, if you like, but by having that, at least we're making a start by setting out a strategy, and then we can seek funding to start to get the evidence together to address those issues and get the right experts in to do that research.
I think also one of the things that we should take into consideration is that TB is not just a medical issue. It's caused by social determinants of health. So we should start thinking about how do other sectors also contributing to dealing with, post-TB life as well. If there's a disability, what are the economic opportunities that are out there for people with disabilities? And that's not the health sector to deal with. That's the trade and industry that should be involved, because TB is a community disease again, and had we averted people from getting tuberculosis in the first place because of these other structural issues, then we wouldn't be in this situation. So I think it's about more getting that multi-sectoral approach into addressing some of the issues that we have. I know like in South Africa as well, we have some social grants if you have some disability. So that's one opportunity to access, and that's not within health. That's actually within the Department of Social Development. So how do we get the other stakeholders involved in trying to address the effects of life post-TB treatment?
And looking down the line, I think one of the important things is if you ever want to convince governments about something, you need to show that it's cost effective, as Kevin pointed out. Now, if you can devise strategies where you're preserving lung health and keeping people off of disability grants, so that you are saving so many million of dollars in disability grants or people who are productive, you've got a very compelling story to motivate for your strategies and what you're wanting to do.
Maybe that's also an opportunity for Department of Health to employ with UHC more community health workers and lay health workers. If a TB patient like Goodman is already doing the job but is now not being paid, but if there is recognition from government that there's real benefit to patients, then there's value for them, then more people could be employed by the Department of Health post TB disease. So they should have done it already.
So we've got a message there for for governments to fund, and we need research funders to fund us. So we need money for for taking things forward. So unfortunately, our time is coming to an end. I would like to really thank our panelists today, Kevin, Ingrid, Jamila, Brian, Tatem, and so I just pleased a round of applause for our panelists who were excellent. And for those of you who have tuned in online and weren't able to catch all of it, or have got friends who weren't able to be here or to take part, it will be now on the union's YouTube channel, which is the Union NGO, and it will be available to watch at any time, and we can keep the conversation going, because I hope that this will be the start of many conversations about life after TB. So thank you very much, everybody.